I am Dr. Van der Bijl, presenting Lecture 5. Just a reminder that this aims to emphasize the core concepts. You must refer to the study guide as well as the chapters in the textbook, and also make sure that you work through the case study and multiple choice questions to ensure that you have mastered the work. Regarding the outcomes, we will be looking at the central nervous system disorders that are very specific to the neonatal population. Hearing and vision assessment is important both in preventative as well as to assess any complications that can occur during the neonatal period, especially due to iatrogenic interventions. And then we will say a few words about parents in the neonatal unit, as they are part of the multidisciplinary team in taking care of their babies. When a baby is born with an abnormality of the central nervous system, one can classify it as either a malformation or a deformation. In a malformation, it implies that there is a developmental defect in which the brain never was normal. In a deformation, however, there was an external insult that then negatively affected brain development, and therefore there is a subsequent abnormality in the structure of the brain. Neural tube defects is then an example of a malformation of the central nervous system that happens very early after conception, and it is less common these days due to two main reasons. Firstly, improved antenatal care, specifically with fetal screening at the anatomical sonar around 18 weeks of gestation, and if the abnormality is then detected, the termination of pregnancy can be considered. And then secondly, the use of folate supplementation specifically decreases the risk for neural tube defects, namely spina bifida, and therefore these conditions have become more rare. In anencephaly, it is a condition where the forebrain is absent. The insult is around 24 days of gestation, and usually a termination of pregnancy is indicated, as these patients are incompatible with life, and they may even suffer either a stillbirth or an early neonatal death. In an encephalocele, there is failure of the midline closure of the skull, and then the brain can protrude through the defect. In up to 80% of cases, this happens in the occipital area. Again, the lesion occurs around 28 days after conception, so it's very early. In spina bifida, there's a developmental failure of the vertebral column to fuse, and this can then also lead to protrusion of the meninges and the cord. In spina bifida occulta, the vertebrae are bifid, but you don't have a protruding meningocele or myelomeningocele. It is quite rare, with only 10% of the population exhibiting abnormalities, and it may be of no clinical significance. You may see lesions over the lower back, namely a deep sinus, a nevus, a tuft of hair, or even a fatty swelling. In a small proportion of people, it can lead to a tethered cord, and as the child then grows, it may become stretched, causing irritation and then irreversible neurological signs affecting the lower limbs as well as the bladder. So one should be on the lookout and examine the baby's spinal column carefully in order to do a risk assessment. Spina bifida cystica has an incidence of 1 out of 1,000 births. The most common form is the myelomeningocele, which occurs in about 80% of patients, where the meninges as well as the cord prolapses through the defect. It can cause paralysis of the lower limbs, and it is strongly associated in the lumbosacral area with Arnold-Chiari type 2 malformation, which is an obstructive non-communicating hydrocephalus with associated abnormalities in the brain and a small posterior fossa. Because of the site of the lesion, these patients often have urinary issues, either with an atonic bladder, which can lead to hydroureter and hydronephrosis, or it can lead to a spastic bladder as a higher motor neuron lesion. Fecal incontinence is also common. Meningocele, it has no neurological abnormalities. It's just the meninges that are protruding, and it does not include the spinal cord. To diagnose disorders of head size and shape, you need to plot the head circumference on the centile chart for the correct gestational age, and you have to perform a good clinical examination to see if you can see any associated signs. When the head circumference plots below the 10th centile, the baby is microcephalic, and there are numerous reasons for that, namely primary or secondary insults. Primary microcephaly is usually disorders of proliferation, and in secondary microcephaly there was normal growth of the brain up to a point after which there might have been a major insult that can then negatively affect the growth from that point onwards. In a macrocephalic baby, the most common cause is hydrocephalus, and here there is an imbalance between the production and the absorption of cerebrospinal fluid, or CSF, and this can then lead to enlarged ventricles, which exerts pressure on the brain and increases the head circumference, and this gives you the characteristic and abnormal shape of the head. In classification of hydrocephalus, there is firstly the non-obstructive form, where there is excessive production of CSF, and an example of this condition would be a choroid plexus papilloma that is just producing too much CSF, which cannot be drained effectively. In obstructive hydrocephalus, there is an obstruction to the CSF circulation, and this can be divided into non-communicating and communicating hydrocephalus. In non-communicating obstructive hydrocephalus, there is no communication between the ventricles and the subarachnoid space, and there are basically three common sites of obstruction. The first is in the aqueduct of Sylvius, where there might be a stenosis. It can also be due to occlusion of the foramina of Luschka and Magendie, which may be the result of intraventricular hemorrhage that leads to basal adhesions. And then lastly, the Arnold-Chiari type 2 malformation that is associated with the myelomeningocele can lead to blockage. In communicating hydrocephalus, one finds that there is damage to the arachnoid villi, which then is unable to lead to absorption of the CSF. We often see this arachnoiditis following intraventricular hemorrhage as well as meningitis. Intraventricular hemorrhage is a condition seen in preterm babies, and it is a rupture of capillaries in the periventricular germinal matrix area, which can then rupture into the ventricles. The germinal matrix is present between the 24th and 34th week of gestation, and it is a highly cellular and vascularized area in the brain. It is basically the factory of the brain, as it forms both neurons and later on glial cells that will migrate outwards to form the developing brain. Because of the location over the head of the caudate nucleus in the floor of the ventricles, it can then easily rupture into the ventricles. The risk factors then include prematurity, and the more preterm the baby, the higher the risk. Babies that have respiratory distress syndrome, specifically if it's complicated by pneumothorax, are at increased risk, and ventilation has been independently associated with a higher risk for IVH. Hypercapnia leads to vasodilation in the brain, and therefore the pressure changes can then precipitate bleeding in that area. Anything that disturbs the baby and causes the baby to be unstable, such as metabolic acidosis, can result in an IVH, and then coagulation disorder can worsen the bleed once it happens. The clinical features of IVH can be very subtle, and in 60% of preterm babies it might be an incidental finding with minimal signs. In intermittent deterioration, this condition can develop over a period of days with increasing signs of apnea where the baby stops breathing, bradycardia, or you can identify a bulging fontanelle. Seizures can occur, and metabolic acidosis can be difficult to manage and it may not resolve. In the worst case scenario, there might be massive collapse with severe neurological signs such as seizures and even a comatose state. Because of the bleed, the baby may become severely anemic and go into a hypovolemic shock. Real-time ultrasound is the golden standard, and one can either do it as a routine screening tool, or you can wait until the baby has clinical signs indicating that there might be an IVH. Using the Papil classification, grade 1 would refer to a baby that has a subependymal germinal matrix hemorrhage, where it is near the ventricle but has not yet broken through to pour blood into the ventricle. In grade 2, there will be blood in the ventricle, but there will be no ventricular dilatation. And then grade 3 is an IVH with a ventricle that is distended by blood. And grade 4 is where there is an enlarged ventricle with blood also extending to the intraparenchymal area. The prognosis for a baby with grade 1 IVH is very good, as is grade 2 where the ventricles have not dilated. But if you have a grade 3, especially if it's bilateral or if there is intraparenchymal hemorrhage, then the outcome is poor and we may have to offer the baby palliative care due to the expected poor outcome. Periventricular leukomalacia, or PVL, is literally a softening of the white matter in the areas surrounding the ventricles, and this can present as cystic lesions that can be identified on ultrasound. In the end, this will lead to cerebral palsy, and typically these patients will suffer from spastic diplegia, where the legs are more affected than the arms. The damage happens to the developing oligodendroglial cells that is in the periventricular white matter, and the most vulnerable period is between the 26th and 34th week of gestation. There are a number of conditions and situations that correlate with the development of PVL, and it's important to note that it can start antenatally if the mother has chorioamnionitis due to the inflammatory markers that can then damage the immature brain as it is neurotoxic. Severe fetal asphyxia, as found with massive placental abruption or cord prolapse, can predispose to PVL, as well as hypocarbia, which specifically occurs when the baby is being ventilated. Hypocarbia leads to vasoconstriction of the vessels of the brain and therefore leads to hypoxia and ischemia in those delicate areas. Any condition that leads to a release of cytokines, such as necrotizing enterocolitis or a systemic sepsis, can also compromise the baby's neurodevelopmental outcome by damaging the white matter. And then early postnatal steroids have been shown to be associated with cerebral palsy, and again the warning that any steroids and stress is actually damaging to an immature brain. Hypoxic ischemic encephalopathy is the clinical neurological syndrome that is associated with a sentinel event that leads to fetal hypoxia and ischemia. These patients often need resuscitation after birth and then might exhibit the neurological signs as well as failure of other organ systems due to the hypoxia and ischemia suffered. The clinical severity can be graded into mild, moderate, and severe. In the mild group, or grade 1 HIE, the patients are often irritable and appear hyper-alert with exaggerated morrow and jittery movements. Seizures are typically absent, and as soon as baby does convulse, it should be graded then as a grade 2 or 3. The tone can be mild hypertonic, and then very specifically the sucking is poor and the babies might have difficulty in feeding. The prognosis is excellent, and most of these infants will show great improvement within the first 24 hours after birth. In the moderate group, the patients are lethargic and may or may not have seizures. The tone is markedly abnormal, and these patients do not feed at all and will require nasogastric tube feeding. The prognosis is 25% risk of serious sequelae such as cerebral palsy and mental retardation. In the worst case scenario, the baby will have severe HIE where the patient is then comatose and can have either no seizures or prolonged, difficult to control convulsions. Severe hypotonia with a flaccid posture is often observed, and these babies have no morrow response. The sucking is very poor, and often these patients cannot even swallow their own saliva. They also have a failure to maintain spontaneous respiration and can hyperventilate or even have apnea. In this case, the prognosis is very poor with an 80% plus chance of either mortality or severe disability if they do survive. When managing a baby with hypoxic ischemic encephalopathy, it is crucial to prevent further damage to the already compromised central nervous system to try and optimize the neurological outcome. It is also important to anticipate and monitor the baby for the multi-organ dysfunction that is sure to follow. As multiple organ systems are affected negatively by the hypoxia and ischemia suffered during the peripartum period, the baby may present with damage to all of these systems. In the metabolic system, it is important to check the arterial blood gas to establish whether the baby has metabolic acidosis. In an HIE patient, there is usually a lactic acidosis due to anaerobic metabolism secondary to the hypoxia and the ischemia suffered. When managing a patient with acidosis, it is important to treat the cause of the acidosis and not just to give Sodabic. Sodabic is not a good idea, and therefore one should focus on stabilizing the patient's respiratory and cardiovascular systems by respiratory support, ensuring adequate oxygenation, as well as considering a fluid bolus or inotropes to stabilize the baby's blood pressure and encourage perfusion of the organs. Hypoglycemia leads to brain damage, as glucose is the main substrate of the brain, and specifically because fluid will be restricted in this patient, it is important to prevent hypoglycemia by screening and regularly checking the baby's blood glucose. Syndrome of inappropriate ADH secretion often happens in babies with brain damage. In this case, because of the inappropriate ADH, the patient cannot pass the urine and therefore has poor urine output, and this leads to edema and fluid overload. Regarding the respiratory system, the patients can often have signs of respiratory distress and also develop respiratory distress syndrome. Transient tachypnea of the neonate is more common, and in patients with meconium-stained glycol due to fetal distress, They can also have meconium aspiration syndrome with the related complications of pulmonary hypertension and pneumothorax, which can further compromise the baby's clinical state. The cardiac system, one should consider that the myocardial ischemia can lead to heart failure. Due to poor adaptation after birth, persistent pulmonary hypertension of the neonate can occur, and then the patent ductus arteriosus due to the relative hypoxia is also a common finding. Renal underperfusion can lead to acute tubular necrosis, and this will manifest as acute kidney injury with oliguria, anuria, and a rising creatinine. In these cases, it is important to restrict fluids until you know that the baby can pass urine, and to start with potassium-free neonatolite to avoid hyperkalemia should the baby not pass urine. In the hematological system, one can screen for DIC as the clotting profile might be abnormal. And then necrotizing enterocolitis is a real risk in a baby that had underperfusion of the gut, as the gut is not an essential organ. And on the first day of life, we often keep the baby's nil by mouth. On the second day, if the abdomen is soft and positive bowel sounds are heard, one can cautiously start feeds and slowly titrate up while checking that the baby is tolerating feeds, and to be on the lookout for signs of NEC. In the pathophysiology of HIE, one should recognize that the central nervous system undergoes an insult which leads to primary energy failure and necrotic cell death. But the next phase, where reperfusion takes place, leads to a transient recovery of cerebral metabolism, and then in the secondary energy failure phase, which lasts for usually 6 to 72 hours after the insult, there is a delayed damage which leads to apoptotic cell death. And this can then influence and give the final picture of hypoxic ischemic brain injury. The therapeutic window, therefore, is in the first 6 hours after the insult, and if you want to target any interventions to improve the baby's neurodevelopmental outcome, it is in this time. For this reason, it is critically important to avoid hypothermia and rather to allow passive cooling for babies at term or near term with a diagnosis of HIE. This is not to be performed for preterm babies who do not tolerate hypothermia well. For them, you should always aim for normothermia. Therapeutic hypothermia or targeted temperature management is indicated for patients with moderate HIE if they are born term or near term. As mild HIE patients will all recover, it is not useful modality for them. And in the most severe of cases, therapeutic hypothermia will not reverse the significant damage done to the neurological system. International studies have proven that the term brain is protected from further injury by this treatment modality. It is important that a specialist center should oversee this management strategy due to a significant risk for complications. The patients should be cooled within 6 hours to a core temperature of 33.5 degrees Celsius, and this is usually done by a rectal probe. The patient will be cooled for 72 hours, after which a very slow rewarming process will take place. Neonatal convulsions, also referred to as fits or seizures, can occur in the neonatal period with an incidence of 5 to 8 out of 1,000 live-born infants. It may be difficult to decide whether a baby is fitting, as the signs are often subtle. It's important to distinguish jitteriness and abnormal movements from seizures. In a jittery patient, it is provoked by a stimulus, and the movements are rapid and oscillatory. The movement of the limb will cease when it is held, and it will not keep ticking away as it would if a patient has a convulsion. The level of consciousness will be normal, with a baby in either an awake or asleep state. In convulsions, we often see altered consciousness with a post-ictal period. No eye deviation will be seen in a jittery patient, but it may be a sign of a convulsion if a baby has eye deviation. To determine the cause of convulsions, it is important to remember the etiology list and then order your investigations according to the most likely causes. In the metabolic group, one should immediately exclude hypoglycemia, as this is often the reason for convulsions in the neonatal period. The brain is dependent on glucose for metabolism, and it can lead to permanent neurological damage if this is not addressed. Hypocalcemia and hypomagnesemia are associated with babies of diabetics and with patients with hypoxic ischemic encephalopathy. Hypo and hypernatremia can lead to convulsions, and then hyperbilirubinemia, where Garen icterus or encephalopathy occurs, can lead to convulsions as well. Under the central nervous system causes, patients with HIE can fit just because of the brain damage or brain edema. Intracranial hemorrhage, such as intraventricular hemorrhage in prematurity, or maybe traumatic birth with a subdural hemorrhage in term infants. Infections need to be excluded, and specifically meningitis. Therefore, all babies that had convulsions should receive a lumbar puncture to check for meningitis. Neonatal abstinence syndrome can lead to convulsions. In this case, mothers that are addicted to opioids or narcotics and other recreational drugs, the patient can withdraw and then convulse because of that. Inborn errors of metabolism is a rarer cause, and then pyridoxine deficiency is also well described. When a patient is convulsing, it is important to start with the resuscitation in the ABC principle. Firstly, to check that the airway is open and clear, and to suction if there is any obstruction. The baby should have a good respiratory effort and be oxygenating well. If not, one can start oxygen therapy, and some patients may even need intubation if the convulsions are severely hampering their respiratory effort. The circulation should also be checked to evaluate the baby's blood pressure and perfusion of the vital organs. Then the principles for treating the convulsions itself is to either treat the cause and to terminate the convulsion and prevent further convulsions. If the patient, for instance, has hypoglycemia, one should treat the hypoglycemia. Otherwise, the anticonvulsants will not have the desired effect, so always look for a cause. In an emergency situation, one must terminate the convulsion, and the first-line treatment is still phenobarb or phenobarbital. Preferably, the first dose should be intravenous at 20 milligrams per kilogram, which can be repeated with 10 and another 10 milligrams per kilogram to reach a total maximum dose of 40 milligrams per kilogram. If this does not work, one can choose between epinephrine infusion over 30 minutes to give a bolus dose, or to start a continuous lignocaine infusion. It's important to not use them simultaneously, as both have significant cardiovascular side effects, and the patients may suffer cardiac arrest if they use simultaneously. Midazolam can be used, and the shorter acting agents, but never diazepam, due to the severe respiratory depression experienced in the newborn. And then it's important to prevent further convulsions by addressing the underlying cause, and then carefully considering whether phenobarb maintenance is indicated and whether the baby can be weaned and stopped. A neonate with hypotonia can be described as a classic floppy infant. These infants are usually lethargic and show very little movement. When observing the posture of the baby, they classically lie in a frog-like position with abduction of the hips and external rotation of the limbs. There are many anatomical sites that can give this neurological picture. And firstly, you can start with the brain. If the brain is damaged by hypoxic ischemic encephalopathy, specifically grade 2 or 3, the patients can appear very hypotonic. It might also be injury of the spinal cord. There can be damage to the anterior horn cells as found in SMA or spinal muscular atrophy. Then the nerve root itself can be injured as seen in a brachial plexus injury. There might be trauma to a peripheral nerve. Neuromuscular junction might be affected if the mother has myasthenia gravis. The antibodies can cross the placenta and cause a transient neonatal picture. And then lastly, the muscles can be affected by conditions like congenital dystrophy. So there are basically then two main groups, namely non-paralytic and paralytic. In non-paralytic, you usually have a weak infant with hypotonia but with normal muscles, and an example here would be cerebral hypoxia. The tendon reflexes may be preserved, so it looks like an upper motor neuron disease, and this will in the end then lead to cerebral palsy with increased peripheral tone. In the paralytic group, you might have a weak infant with hypotonia and muscular disease, as you would see with spinal muscular atrophy, also called Wernicke-Hoffmann disease. And here the tendon reflexes will be absent and have the clinical picture of a lower motor neuron disease.